Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Kheshgi. Dr. Kheshgi is a clinical assistant professor in the Division of Rheumatic Diseases at the University of Texas Southwestern Medical Center. She received a master's in pharmacology from the University of Cincinnati, Ohio, and she completed her rheumatology fellowship from the University of Texas Southwestern Medical Center. Now I'd like to request Dr. Kheshgi to begin today's session. Thank you.
So hello, everybody. Good morning. So glad you all are here on this Saturday morning, when you could be doing other things, but I guess that's because you have a thirst for knowledge. So welcome. So what I was asked to do was to just kind of take you on a ride with me through my journey towards becoming a rheumatologist. So I'll go ahead and start with that. It's long. It's been several years. And then at the end, I've got a little surprise for you. I thought I'd kind of let you in a little bit on what we do on a day-to-day basis, although, it's a huge subject, so we can't cover it in one session. But, just kind of give you a little bit of some hardcore knowledge as well. So I'm going to go ahead and start out with when the journey started for me. I grew up in Pakistan, and there, we had we kind of make up our mind where we want to go pretty early in life. And so I always wanted to be a physician. And, we graduate from med school pretty early over there because, high school is 10 years and then we have 2 years of pre-med instead of 4. So we don't do humanities or anything else. We just concentrate on hardcore sciences, physics, chemistry, and so on and so forth. So biology. And then we have 5 years of med school. So by the time we graduate, we are still in our early 20s, like 22, 23 years old. So it's some people are very focused. For the rest of us, we still kind of make up our mind which direction we are going to go in. And there's plenty of time to do that as well. So I graduated, from the pre-med and ended up in med school in my city. Spent 5 years there, which was a wonderful, wonderful time, a lot of hard work, but it's always a very, intense knowledge. And once I graduated, I became a demonstrator, what they call over there, which is basically a lecturer of anatomy at the med school. So we do 1 year of just an internship, and then we decide what direction we are going to go in, whether we are going to go into academics or whether we are going to go into fellowship or, whatever we want to do. So I decided, it was offered by the dean of our college. He picks the top merit to do the teaching at the med school. My initial thought was that I'm going to go ahead and go into something like pathology or pharmacology because anatomy was not my forte. It wasn't my favorite subject as a medical student. But lo and behold, I became a lecturer of anatomy. And that was because, our principal, he kind of talked me into it. He says, well, in all the others, most of the time it's the professors who do the lectures and the demonstrators, they just end up most of the time in the labs. Whereas in anatomy, you're the direct teacher. So I did that for, and so I have wonderful students, so I was about 23, 24 years old and had all these young students coming in who were in their, late teens, early 20s. So it was a very nice journey. And I still have all those people who are my friends, worked hard. And so, so I was teaching them and teaching myself at the same time. And, so I think it was just a wonderful experience. About a year into it, we decided, I got married and moved to the US. So totally different, in Pakistan, when I was doing my internship, what made me move towards academics was that, we talk about socialized medicine and we talk about pay for service and insurance-led healthcare. And there's always a debate going on about what is the best. And in Pakistan, we have totally socialized medicine. So, anybody and everybody has access to healthcare, which is wonderful because you can walk into any hospital. You don't have to have insurance, or at least they did. And now they're kind of changing the system a little bit. And you could get treatment. The downside was that, the resources are limited. So, either you didn't have the medications available, so there were plenty of doctors and there were plenty of patients, but the resources are very limited. So sometimes you won't have the medicine which needs, the patient need to be treated with. I mean, I have really done, I did a rotation and surgery for about 6 months, and we didn't sometimes have catgut or silk to sew the patient. So, anybody who would come in who could afford it, we would ask them, could you get like double of what you need? So then we would put the rest in our little, a stash to use on the next patient who could not afford it and, who needed surgery. And so it was tough. And, so I got a little bit disheartened and said, well, you know what, I'm just going to go into academics because I'm not sure how much difference I'm making here. But that kind of, put everybody in overdrive. So we had a lot of, we had like a students federation for poor patients, and they would supply medications, they would collect funds, and they would make sure they had a blood bank. So anybody who needed a blood, you could ask them even if it wasn't available at the hospital. And I still remember but their thing was that if they donate, if they bring blood for a patient and the patient has relatives with them who can afford to give blood, they would take it from them to fill whatever has been taken out of the blood bank. And unfortunately, because of illiteracy or whatever, people would come in and refuse to give blood for their own kith and kin who was there needing blood. So sometimes, I still remember at least twice during that 1 year of residency, I gave blood, and some of my friends, we got together and said, okay, take our blood and just get blood for this patient here. So it's very one-on-one, and it's very intense. But it can also, for a 23, 24-year-old person, it can be a little bit disheartening. So, I said, okay, let me just spread knowledge instead of trying to, make a little difference, which may be too little. So having done that after anatomy, so we moved to the US, and I kind of stayed with that. I wanted to get into academics. Lo and behold, we ended up in Huntsville, Alabama, which was, it had a couple of good hospitals, but there was no med school. And, so I wanted to get into a graduate's program, but the nearest university was Birmingham, Alabama. So I also had to take my GRE because, even though you have a medical degree, you can't get into a grad school without GRE. So I did that, which wasn't, of course, when you take your GRE, you have to kind of get reintroduced to your high school math, which you've forgotten and what have you. And then I got into the University of, I got into the master's program for public health. Unfortunately, my son was about 4 months old at that time, and couldn't put him. There was no help at all. We are pretty much on our own when we decide to move and immigrate. We go to a new country, a new place, a new city. You have no friends, you have no family to take care of anything. So you're pretty much it. You're doing everything on your own. It was just difficult. He was sick a lot of times, put him in daycare, and, he would come home sick every week. So I decided to postpone it, but they were really nice out there. So they have so the program I got accepted in, it was a 4-day program, but Birmingham was about 4 hours away from Huntsville. So we had to, I was expected to drive down there. But when I told them I'm not coming, they said, well, next year we are going to make it a weekend program. So people come in on Friday, Saturday, and Sunday, 12-hour days, long days. And then you go back on Monday. So that way, you take care of the family during the week. So there are innovative ways of kind of, doing things. And as physicians and as medical students, we kind of make the best of whatever is thrown our way. We don't wait for things to be right. We just make the best of what we have. So I was going to do that, but thankfully around that time, my husband got a job in Cincinnati, Ohio. So that was a windfall. We moved there, and it was a beautiful city. Love Ohio. I still miss it. And I applied to the, University of Cincinnati has a College of Pharmacy, which is pretty good. And I'm always trying to, falling behind. So we didn't even get there till like February or March, and, all the admissions were already done. But when I applied, they did accept me, and they said, you can start in September. So that was great. And they, full tuition, full scholarship. So I didn't have to pay any tuition for my PhD program. I got into the PhD program for pharmacology. So the way they divide it is, if you are into a graduate program for a doctorate, they have about 90 hours of coursework, and there is, I think it's about 3 years or 4 years, about 140 hours of research. before you can present. And it was a great experience. It was, I was really exposed to hardcore research. So we did some animal studies, seeing how histamine affects release of certain chemicals in dogs. Did a little bit of veterinary medicine there. My thesis was on transport of fatty acids across cell membranes. So what that entails is that, the thought is that, cell membranes is a lipid bilayer and fatty acids just kind of diffuse across. But the hypothesis there was that since trans fatty acids are supposed to be much worse for you as compared to cis, maybe the transportation across cell membranes is different. And the advisor I was working with, his thought was that he had done some preliminary studies that cis fatty acids are internalized because they're not just diffusing across the membrane, they're actively transported into the cell. And that the trans kind of hang around outside and do all the damage. So we used an instrument called flow cytometry, and we did that. But, the funny thing was, when I did all those studies, guess what was being internalized? It was the trans fatty acids that were going in instead of the cis. And I thought, well, maybe I just don't know how to do this right. So we repeated those experiments several times. And turned out that it was always the trans fatty acids that were moving across the cell membranes and the cis fatty acids were not. So then we did publish a paper out of it that the, orientation of fatty acid, affects the way they get transported across cell membranes. Also did some other studies with, they see in people who are with, treated with cisplatin, it's very nephrotoxic, but in diabetics, it's not nephrotoxic. So what is it about the diabetic kidney that makes cisplatin not nephrotoxic? So, we kind of made the mice diabetic by, certain chemicals, and then we cut up their little kidneys and used an instrument called atomic spectrophotometer to see if they were just not concentrating that metal, because it's metal, so you can pick it up, that they were just not concentrating it, and that's why it was not causing the damage that it does in normal people. So that was a very interesting journey, but these days research is not the blood and gut research, which I was thinking I was getting into. It's very much biochemical, it's bench research. And another thing you need to think about if you are thinking of the research pathway is that as physicians, we are used to, positive reinforcement. We introduce our patients. We go see our patients, we treat them, they get better, they feel wonderful, we feel wonderful. So it's instant gratification kind of deal. Whereas with research, just like I told you with those experiments with the cisplatin and cis fatty acids and trans fatty acids, you can do research for years and years and realize that all of it was trash. You really didn't get anything out of it. And then you kind of go back to square one. And then also you have to have a lot of patience sitting at your desk and doing that, which was just not my personality. But if you don't like interacting with people, then research it is, it's great. They're fixed hours. Sometimes you do stay over, but if you're running an experiment, but you can work around your hours. It's not like medicine when, you just have to deal with whatever comes your way. You don't choose your time. So cut a long story short, I decided that I was not, I had already completed my coursework for PhD. I had completed the 90 hours and I did it pretty quickly in about a year and a half, but I had enough research to get out with a master's if I wanted, but I had also kind of studied for my USMLE exams around the same time and took those and passed. Had applied for residency. So I got accepted into an internal medicine program in Michigan, Detroit, Michigan. It's Pontiac, Michigan, actually, St. Joe's Hospital. And a lot of them, you wasted that year. But just remember, education is never, ever wasted. To this day, I have not regretted my stint in, in the grad school. And whatever I learned there during our residency, they did have a 2-month mandatory research they had started. So we had to do that. I quickly got accepted into that program. because, I had, they said, we don't want to waste time with people who don't know how to use the pipettes, who've never been inside a lab, because those 2 months will just go trying to teach them that. So it was really interesting because I did that, got the first prize in research during my, my residency program. And that was all thanks. So the research we did there was, carbonic anhydrase antibodies in people with endometriosis. Endometriosis, again, still a mystery. Nobody knows if it's autoimmune or if, what causes endometriosis. So that was one step, and it was serendipity that they found some carbonic anhydrase antibodies. So did some work on that, which was very interesting, and completed my, my internship and my residency from St. Joe's Hospital, Pontiac, Michigan. And, at that time it was thought, that was like the mid 90s, 96 is when I grew, 97. And so it was like everybody wanted the gatekeeper model. The insurances were taking over, they were gatekeeping access to specialized care. And I got a job offer right in the, so my director, he did offer me a position as the chief resident, which I kind of thought I needed to get on with my life. So I said, I refused. I said, no, I want to start working. So excuse me, became an internist, excuse me, at St. Joe's. They had a Mercy Medical Group, which was interesting. But internal medicine, really, it's huge, and especially when you are the gatekeeper and when they are limiting care to specialists, you have to know everything. I mean, literally, I was draining before even I became a rheumatologist. I was draining elbows and knees and, just kind of, it's just a lot of, and then they want you the RVU system, so you don't really have time to think much. And you kind of keep going, and access to specialists was somewhat limited. But thank God, like I said, everybody kind of talks about residency hours being too tough, but they pretty much prepare you for whatever you want in life later on. Nothing is bad. So but when I was doing residency, that ATR cap was not there. We used to work like 120, 130 hours as interns. And then we became, second year, third year residents. It was a lot easier because it kind of got down to 90 to 100 hours versus, keep going. There's no time off for residents or interns. So it was nice, but, I felt that I would be much more productive if I could concentrate on one thing and be really, really good at it rather than try to do everything under the sun. Also, by that time, 5 years in Michigan, I was kind of tired of the snow, and I know some people love it. Growing up in Pakistan, I wanted to be in a warmer place by February. I had to get out of Michigan because, go someplace warm. So we moved to Dallas. And again, I'm always kind of the tail end of applying for things. So we made the move around March or April, I think it was, when we decided that we'll go to Dallas. And so I applied thinking that I won't get a job, obviously into the fellowship program until next year. But the good news is that I did get, so I applied around May, and they called me in for an interview, and they said, well, you can start in July. Which was really a wonderful surprise because they put me on an NIH grant. Our director over here, he was very resourceful. So not only did he have the Medicare money for fellowships, he also had NIH money and so on and so forth. So at a time when there were just about, I think, 79, I was told fellows in the United States in rheumatology. UT Southwestern Medical Center here in Dallas had 10 of those 79. So it was a huge program. There were like 3 first year, 3 second years, 3 third years who were continuing into research. So a lot of people ask me, why rheumatology? And the whole crux of the matter is that when I was doing my doctoral work in Cincinnati, we took a few courses in immunology. And whatever, it was a brand new field, what we know about immunology now, that was not known, the textbooks were way behind. So our teacher used to come in and he would just give us these reading material from journals because the textbooks weren't just up with it. So it was just a huge new field, and it wasn't something, yeah, me too, been there, done it, just a different form of medication to use. It was a whole brand new field. So my interest was allergy or rheumatology. And, in Galveston here in Texas, they do have a combined allergy rheumatology program. It's a little bit longer, instead of, I think, 3 years for rheumatology, 2 to 3 years, depending on what path you want to take. It was a 4 to 5 year program. But thankfully, since I got accepted in the rheumatology program, I got accepted in the other program also, but that would have been the usual timeline. You apply in March, you don't get until next year. So I decided to start with rheumatology. And I think it's a really, really good decision, because I've seen at least 2 allergy, immunology, rheumatology kind of combined, how should I say it, combined graduates from these programs, and they're either doing allergy or they're doing rheumatology. I've not seen anybody do both. So again, like I said, medication, education is never wasted. Obviously, they have much more grasp on this, but I think that was a good decision. I think just God propelled me in that direction, and I went and, got accepted. So the rest is history. So it was, for the fellowship program, you could do 2 years just clinical, or you could do an extra year for research. Of course, I had enough research under my belt, so I didn't want to do that. I'm more interested in clinical research anyway. So I completed that and joined a private group here. It's a big group of rheumatologists in Dallas. We were about, I think I was the 7th person to join the group. Now we're about 20. We are still about just 8 partners. And we have a lot of salaried physicians, and then we have the mid-levels. And again, it's just been wonderful. And the funny thing is, like I was telling you, there was so much new information in rheumatology and immunology. When I graduated from my fellowship program in 2000, the best we had to offer people was methotrexate. Of course, steroids are first line. And then we have, a few disease modifying agents like methotrexate and cyclosporin, and leflunomide came out, I think, in 98 or 99, and we were thrilled. At least we had one other medicine to offer. But since 2000, the code was cracked, and we have these wonderful biologics, the TNF inhibitors, the TNF receptor blockers. So we have a ton of new medicines. And by ton, I mean, for us, coming from 3 to 4 medicines, having a choice of a dozen medicines to choose from is just wonderful. And the whole paradigm has changed. So in the past, people would get treated with anti-inflammatories until all the joints were deformed, and then they would move on to the disease-modifying agents. However, now we hit them with whatever we get to start with. So the whole process is to reverse the disease course, calm the immune system down. We don't wait till all the joint damage is done and then put them. We try to prevent joint damage. So whereas in the past, you might have seen people who had, rheumatoid arthritis or psoriatic arthritis or any of these, I mean, you can recognize them walking down the street. Whereas, they'd had their knees replaced, their hips replaced, their small joints in their hands replaced. Whereas now you can't even tell people have rheumatoid arthritis or psoriatics or any of these others because people come in. I mean, they say when they ask for FMLA leave to go to visit the doctor or whatever, and they're told by their colleagues that, where are you going? I mean, you don't have arthritis. What are you talking about? So they say, so they look on them as malingerers, which is a good thing for the rheumatologist, because we've got them to the point that we are throwing them into remission and they have no signs or symptoms of the disease. So I think the most research has been on, of course, spondyloarthropathies, rheumatoid, psoriatics, lupus. We are still lagging a little bit behind, but still we have 2 or 3 more choices now than we had in the past. And by and large, again, some of our diseases are so rare, like relapsing spondylochondritis and so on and so forth. They're like 600 to 700 patients throughout the US. So obviously, the drug companies, it's not worth their while to look into it. Although, I think there's a lot of practical experience. So I think it's a great time to be a rheumatologist. So if any one of you wants to follow that course, I would really encourage it. And so I think that was my journey. And I'll just give you a little bit of a taste of what, I think if you know this, if at the end of this lecture, you can tell the difference between inflammatory and non-inflammatory arthritis, you are way ahead of the curve. You're way ahead of some of your colleagues, even some of the, internists, primary care physicians, because, these are rare diseases. So people don't see them on an everyday basis. In a busy practice, when you see them once in a while, you tend to miss them. So so I'm doing this lecture later this year. So I thought I would just introduce you to it. So we can go on to the next slide. I always tell my patients, arthritis is arthritis, but there are multiple types of arthritis. 1 in 4 adults in the US has arthritis. It's significantly, it's not just something you can put on the back burner. It limits activities, it limits your work time, it takes away from your earning capability, and it is a growing clinical problem. Next slide. Can I move the slide? Okay, there I can do that myself. So RMDs are rheumatic and musculoskeletal diseases. There's a diverse group, so it's not just one disease. It can affect adults as well as children. So it's not a disease of old people. It can be from diseases of the immune system, inflammation, infections, or it could be just a gradual deterioration of the joints because of muscle and nerve diseases as well. Over time, they get worse if untreated, and they lead to significant disability. Simplest tasks become impossible. I tell my patients, of course, when they come in and they've heard the word lupus or they've heard rheumatoid arthritis, and they have no idea what that is. So I always tell them that there are 2 big groups. I said there are more than 200 varieties, but there are 2 big groups, inflammatory and non-inflammatory. Inflammatory is what we are dealing with right now. So the big inflammatory includes all those conditions, lupus, rheumatoid, psoriatics, whereas non-inflammatory are things like osteoarthritis, traumatic injury to the joints, so on, which are confined to the joints. They're more of a mechanical local problem, whereas inflammatory are the ones in which the joints are just the innocent bystanders and they have been attacked by the immune system. So as this is pathology 101, I know we all learned about rubor, calor, dolor, so on and so forth. So redness and heat are cardinal signs of inflammation. Swelling can be seen in inflammatory or non-inflammatory. Pain, of course, can be seen in both inflammatory and non-inflammatory, although it is, of course, a sign of inflammation. And loss of function can be common to both. So the first 2, the redness and heat, will obviously make you think inflammation, whereas swelling, pain, and loss of function is common to both inflammatory and non-inflammatory. So what are the types of inflammatory arthritis? There are multiple. These are just the most common: rheumatoid arthritis, psoriatic, ankylosing spondylitis, reactive arthritis, arthritis associated with inflammatory bowel diseases like Crohn's disease and ulcerative colitis, associated with other autoimmune disorders like lupus, polymyalgia rheumatica, which is pretty much a older form of rheumatoid arthritis. Of course, it behaves totally differently. Crystal-induced arthritis, which includes gout. And of course, infections. Never forget those infections. And especially in rheumatology, when you have people on immunosuppressive medication, then they have a swollen joint. Don't presume that it is just a flare of the disease. Always be on the lookout for infections. Non-inflammatory arthritis, like I said, osteoarthritis, hyperflexibility syndromes, regional soft tissue syndromes, fibromyalgia, structural disease, complex regional pain syndromes, which usually follow things like, injury or strokes, neuropathic pain syndromes, bone tumors can cause pain, vascular issues can cause osteonecrosis of, various bones, most commonly the femoral neck, and that can also cause arthritis. So the most common thing, if you see a monoarticular joint, think gout or sepsis. You can always see it in people with psoriasis. So if they have history of psoriasis, you of course can think about that. Pauciarticular, meaning less than 4 joints, that can be seen in psoriatic, crystal-induced, or spondyloarthritis. Polyarticular tends to be more likely to be rheumatoid arthritis, although you can see it in lupus. You can also see some psoriatics with polyarticular involvement. I've even seen polyarticular gout. So, you have to keep your mind open, but these are the most common. For starters, just think if it's one, it could be gout or septic. If it's pauciarticular, think psoriatic arthritis. If it's polyarticular, think rheumatoid arthritis. I'm just trying to make it simple for you guys so your mind doesn't go all over the place, and you'll learn that with time. Now, clinical differences. This is very, very important. Just remember this slide. So morning stiffness, very important. If it's rheumatoid you'll have at least an hour of morning stiffness. By definition, we say you should have it persistently for more than 4 weeks. Persistent, painful, swollen joints and morning stiffness. The reason being that if you, if it's a viral syndrome or something, it goes away. If it's rheumatoid, it won't. It will stick around. And you have at least an hour of morning stiffness. Whereas if it's osteo or something else, you have 15, 20 minutes. Anytime you've been sitting, you can be stiff, but that's what we call the gel phenomenon. It's different. History of trauma is present in non-inflammatory. There's no history of trauma in autoimmune disorders. There's no history of infection. Usually, inflammatory arthritis have a chronic onset. So, you're getting worse and worse and worse. Whereas in traumatic injuries or osteoarthritis, osteoarthritis could be gradual as well, but trauma will obviously cause acute onset. Symptoms worse with rest. In inflammatory arthritis, they are better with rest in other diseases. And we've already talked about polyarticular. Then constitutional symptoms may be seen in, of course, in inflammatory arthritis, depending on what the disease is. So in lupus, you will have multiple other constitutional symptoms, fever, weight loss, fatigue, all of those can be seen. In rheumatoid, usually it's the non-weight-bearing joints versus weight-bearing joints in diseases like osteoarthritis. Physical exam, extremely important. We've talked about constitutional symptoms, rashes, which can be, of course, seen in people with, psoriatic arthritis will have psoriasis, lupus rashes, photosensitivity, dermatomyositis rashes. So just look at the skin. Skin is extremely important to rheumatologists, almost as important as to dermatologists. Raynaud's phenomenon can be seen in people with scleroderma, lupus, mixed connective tissue disorders. Mouth sores can be seen in lupus, alopecia, conjunctivitis and iritis, very commonly seen in spondyloarthritis, although it can also be seen in rheumatoid arthritis. Sinus issues, people seen with polyangiitis with granulomatosis, which was previously called Wegener's. Chest pain, serositis, costochondral pain or fluid around the heart or lungs can be seen in people with lupus. Abdominal pain, diarrhea, that can be seen in inflammatory bowel disease in association with joints. Multiple joints, of course, warm and swollen. That's kind of a no-brainer. Peripheral neuropathy. Again, some people will come in with a neuropathy and say that they have joint pain. So you always have to be careful, especially in the hands, whether it's carpal tunnel, or whether it is really a joint issue versus a soft tissue or nerve issue. Physical exam in so we've talked about the inflammatory arthritis. In non-inflammatory, you have no constitutional symptoms. Of course, there's bony hypertrophy because it's been going on for a while. Crepitus in the knees, although you may not have it if they have fluid around the knees as well. There's swelling of the joints, but no warmth. This could be hyperflexibility. So people with hyperextension syndromes will always have some kind of joint pain. They have more arthralgias because their joints are held in these strange positions. Lab tests, of course, positive serologies in people with rheumatoid arthritis. You're looking for a positive rheumatoid factor, positive anti-CCP, mixed connective tissue disorders, lupus. They all have their own serologies. Elevated inflammatory markers, that's SED-rate and CRP. Anemia is a very common thing we see in inflammatory arthritis, thrombocytopenia or thrombocytosis. Thrombocytopenia more common in people with lupus, thrombocytosis in any kind of inflammatory condition, leukocytosis or leukopenia. Hepatic function test may be off, MGUS, I find 100, monoclonal gammopathies going around, and you always have to work them up to make sure there's no associated underlying multiple myeloma. Hyperuricemia, hypoalbuminemia, hypercalcemia, elevated ferritin is a very common thing we see in people with inflammatory conditions. CK and aldolase will be elevated in people with polymyositis or dermatomyositis. Proteinuria, red cell cast seen in people with lupus most commonly. Joint fluid. And again, anytime the joint is swollen, if you can, please do aspirate it. Do not leave it alone because one, you are making the patient feel more comfortable by taking all that excess fluid off. And two, it's extremely important, diagnostically. So the gold standard for diagnosing gout is still identifying uric acid crystals. You can look for infections and of course the cell count. So if it's less than 1,000, it's usually going to be osteo. If it's up to 50,000, it could be inflammatory. Greater than 50, it's probably septic unless it's tuberculosis or gonococcal, in which case the cell count is low. And of course, crystal, which we've just talked about. So I know we've all, we've heard that, when nobody wants to talk to you, they say, talk to the hand. in this case, for rheumatologists, hands give us, I think, at least throughout my practice, they give us at least 80% of the information we can get from the hands. And this is just a very basic, cartoon of that. So the DIP joints most commonly involved in people with osteoarthritis, psoriatic arthritis. So there are two diseases you'll think of if you have DIP joint involvement: osteoarthritis and psoriatic arthritis. PIP and MCP joints can be seen in osteoarthritis, lupus, rheumatoid. Rheumatoid most commonly involves the PIPs and MCPs. And you can also have hemochromatosis, that usually affects, and this is a pearl for you, it usually affects the second and third MCP joints. So if those joints are swollen, I always, and they don't fit into the clinical picture for any of the other disorders, I always check an iron profile to make sure we're not missing hemochromatosis. Wrist joint involvement, again, gout, pseudo-gout. Carpal tunnel syndrome is usually just numbness and tingling in the thumb and the index middle finger and maybe half of the ring finger. And so very important, and you can do certain tests, the Phelan's test and the Tinel sign to make sure it's that. And then again, a lot of time they'll complain of thumb pain. Now, if it's an older lady with subluxation of the CMC joint squaring, it's osteoarthritis. If it's a younger woman who has had a baby or is doing repetitive use with the hands, you think decurvent synovitis. And, of course, there are tests for that, and you can do that. And there's tenderness over the tendon. So it's not actually a joint issue, it's tendinitis. So if you remember this, the distal joints, the PIP, the MCP joints, and the CMC joints, if you look at those, you've got pretty much an idea about what's going on. And of course, if you have dermatomyositis or polymyositis, you'll also have those rashes on the hands, the Gauthron's patches, the heliotrope rash around the eyes. So I'm just going, I think pictures worth 1,000 words. So I've just thrown in a few pictures at the end here. And and this is a patient of mine. These are all from my patients. This poor woman she had the swelling as you can see, in the fourth DIP joint on the left hand. She went to the hand surgeon who did surgery. Of course, it got redder and worse. She was sent to the infectious disease specialist who put her on oral antibiotics, didn't work, put her on IV antibiotics, because whenever they do a bone scan, it just shows inflammation there. So they say, it's a hot joint. So let's put her on IV antibiotics for osteomyelitis. She came to see me. As you can see, the nail over there, it's got a little bit of onycholysis. And I'm not sure if you can, you see this one is a little bit more swollen as compared to this. And of course, this is the nail over there. So, so when I saw her, I knew what she had. I said, you've got psoriatic arthritis. Very nervous lady. By that time, one of her toes had swelled up and one of her ankles. But she, by this time, has an appointment with an infectious disease specialist at UT Southwestern, as well as a dermatologist. So I told her, I said, you go ahead and do your rounds and then come back and we'll treat you for psoriatic arthritis and you'll be fine. And she did come back. They still told her, the dermatologist over there even did a nail biopsy and said, well, there's no fungus, but I don't think it's psoriasis either. The problem with psoriatic arthritis is that most of the time you have to have it for about 10 years before the joints will be involved. However, being a rheumatologist, I see plenty who either give no history or don't know they have it. It's hidden in their scalp. They're thinking it's just dandruff or something. And thankfully speaking, this lady is doing great. She has no more swelling. This is just, her wrist, which I was trying to show you. So it is subtle, but you have to pick it up. So anybody can tell what's going on over here? So you see, this is swollen toe. So this gentleman again had swelling of the index and ring finger of his right hand. He also ended up with a hand surgeon because that's what folks think of first. He had an MRI of the hand, was told he had inflammation, was put on the list for surgery. I don't know what they were trying to remove surgically, but he decided that he will also see a rheumatologist in the meantime. So he came to see me. He was scheduled for surgery the week after, and then he has this swollen toe. This is what we call sausage digits. As you can tell, it looks like a sausage, right? So I told him, I said, no. And he He did have some psoriasis, not very, very rampant, but no history of arthritis or anything else. So I said, well, let's go ahead and put you on a little bit of steroids. This will take care, but we need to treat you for psoriatic arthritis, not, put you through surgery. And actually, this was the third patient I've seen. Two of them had been to the surgeons already and had surgery. So I called the surgeon. I said, can you please get him off the list? Let's treat him if he, so I said, what did you see on the MRI? Did he have a torn tendon or what are we doing surgery for? And she said, no, it was just a lot of inflammation. So I thought I'd clean it out. So I said, well, we can probably do that medically. And thankfully, he's doing great as well. And the learning curve is that same surgeon is now sending me people with sausage digits without me having to wait to call her. So that's great. We all learned. So look at the hands over here. Now what you see is, you see some swelling of all of these joints, but as you can see, the skin is very, very tight. This is a patient with mixed connective tissue disorder. They can present with rheumatoid arthritis as well as scleroderma. So she had CREST syndrome, limited scleroderma, plus rheumatoid arthritis, mixed connective tissue disorder. This is an unfortunate patient, again, with mixed connective tissue disorder, features of rheumatoid arthritis and scleroderma. This is diffuse scleroderma. As you can see, she has had gangrene of the digits with autoamputation here. She's got swan neck deformity here. She's got the skin discoloration, which is very typical in people with scleroderma. This is a patient who, again, you don't see this at least you don't, I tried that, you will never see it in my patients. This is a patient I recently inherited, has a 20-year history or so of rheumatoid arthritis. She's just on leflunomide and refuses to go on TNF blockers despite having active disease, high inflammatory markers. She has got everything you can think of. So she's got the swan neck deformity. She's got the rheumatoid nodules. So these are the swan neck deformities she has. She has huge nodules on her elbows as well, some swelling. I have been seeing her for a year, and to date, she has still refused any further therapy. So she just takes steroids for a flare, and she's just scared of the side effects, which is, again, with Google, Mr. Google available, and people are always looking at side effects and getting scared. So one way I talk to them is I say, your chance of deformities is greater than 50%. And, again, this is not just joint deformities. If the inflammation continues, it can affect your heart, your lungs, your kidneys. It can increase your risk of infection. So it's a multi-system disease. It's not just the joints that you can live with your joints. So we need to get rid of the inflammation. So I tell them that, well, your chance of having the side effect from the medicine is about 3 to 5%. Your chance of being disabled and having all kinds of other issues is almost 50 to 60% without medication. So you take your choice, and some of them I'm able to convince, but some of them I'm not. So I do the best I can. So this was to say, this refers to my last slide. So if your symptoms on Google, if you want second opinion, I can check Yahoo. If they're not going to listen to their doctor, that's always a choice they have, but that never works. Medicine is the art of medicine. It's not pure science. There's a lot of art involved. There's a lot of, experience involved, things you can look at and recognize. You can look at patients and see they're not doing good, and Google will just not do that for you, or Yahoo. And I just threw that a fun slide. This is the, when I had first joined the group, and they kind of did, I think it was a Christmas party, and they got pictures from all the partners at the time from when we were in college. My picture here is from med school. So, we are all young ones, and, it seems like a marathon task getting to where we get, but, you just stick to it. Persistence gets you there. Consistency keeps you there. And hopefully everybody will do just fine. So I'm going to go ahead and open it to questions now.
Thank you so much for your time this morning. So I'm Robin. I'm a PhD student at Johns Hopkins. I'm actually studying pharmacology. So our first question is, since there's overlap between rheumatology and immunology, because there's immune system involvement in both specialties, how do you differentiate who a patient should see?
I get a lot of, that's a wonderful question, because half the time, half of my referrals these days are coming because either the patient has a positive ANA or quote unquote, something autoimmune is going on. So, they're not esoteric. Unfortunately, no, there are fewer patients, so people are not exposed to them that much. So they think it's very hidden and esoteric and, something only a rheumatologist can figure out. But there are very, defined syndromes for rheumatoid arthritis, for lupus, for scleroderma. If you have allergies, I get a lot of patients with hives. The people with hives and shortness of breath, they belong to the allergists. They don't belong to, of course, the rheumatologists. I always look and make sure they don't have any joint involvement. I check their serologies because, interstitial lung disease can be associated with a lot of our conditions as well. So, one of the physicians here at Johns Hopkins, Michelle Petrie, she has got the largest cohort of lupus patients, and she's kind of the guru on lupus. So she says the R in rheumatology stands for real doctors. And I think she's not tooting her horn. The thing is that we have to look at patients from head to toe. So to answer your question, the immunological systems associated with different diseases are very distinct. So, like hypothyroidism is an autoimmune disease, Hashimoto's, but people with Hashimoto's have very distinct syndrome. They have nothing like rheumatoid arthritis going on. So you can tell. And I've recently had at least 2 young patients. And again, this is a pearl that you all might want to carry home too. They were referred to me, both young in their 20s, referred to me for quote unquote Raynaud's. They have blue fingers, they have blue toes. They had done the whole workup for lupus, scleroderma, everything negative, and finally they threw up their hand and said, go to the rheumatologist. So the first thing you always do is look at the medication list. Guess what they were on? Any takers here? Okay. So yeah, this I've thrown that out even amongst group of physicians, and they couldn't figure it out. They were both on high dose Adderall. Now, Adderall can cause vasculopathy. So I told them, I said, well, you go ahead and talk to your physicians who are prescribing them, get off it, and we'll see, because you don't have rheumatoid, you don't have lupus, you don't have any of these diseases. Similarly, recently I got a patient with granulomatosis with polyangiitis, renal failure, discharged from the hospital, comes in, and look at his medication list. He's on hydralazine, 100 milligrams 3 times a day. Guess what hydralazine causes? It's known to cause drug-induced lupus. It's known to cause, I've had at least 2 patients over the years, granulomatosis with polyangiitis induced by hydralazine. So then again, I pick up the phone, talk to the, I said, maybe it's real, maybe it is his, and it'll continue, but we need to get them off the medications here and see what's going on. And I'm pretty sure, like my other 2 patients, that he's going to be just fine once he's off he's on dialysis right now, actually, it was that bad. But I'm hoping that once he gets off the hydralazine, we'll be able to get him off dialysis as well. So again, to a short answer to your question, distinct syndromes, very easy to diagnose. Very not well to diagnose, to separate.
Well, your patients are very lucky to have you.
I hope so. I'm just doing my best, putting my 2 cents in.
So are there specific risk factors we know for development of rheumatoid arthritis? And is there anything that patients who have these risk factors could do to mitigate their risk?
So that's $1 million question again. Wonderful questions you're putting forward. So we don't know. So we definitely know there's some genetic predisposition. So if there's a family history, you may or may not develop it. So again, it's not a given. Similarly, with spondyloarthropathies, there's a strong genetic predisposition to HLA-B27. However, 8% of Caucasians have the gene, only 1% ever develop the disease. Of course, we don't go checking it in everybody. We only check in people who present with symptoms of spondyloarthropathy. So there is a genetic predisposition, but that doesn't mean that just because you have the gene, you're going to develop it. Something in the environment makes your immune system lose that self-tolerance. Now, what exactly is the trigger, whether it's an infection or whether it's a viral infection, whether it's a chemical in the environment, we just don't know at this point. How do we do to mitigate it? One thing that helps and has helped always, and I tell my patients, the ones I'm able to get off medication, one is stress management. Stress does not mix well with the immune system. So you have to get rid of whatever. I know life is life, you have to deal with what comes your way, but stress, behavioral modification therapy, extremely exercise. Even my patients who are on medications, the one who, increases the endorphins in your brain, the best antidepressant known to mankind, which most of us don't even think about, is exercise. The ones I'm able to take off medications are the ones who stick to their exercise program. I want to get them to the point where their joints are not hurting so they can exercise. And price, if you can control these two on a general basis, and of course, all kinds of diet fads keep coming out these days, is turmeric, whatever. So just a healthy diet, which you would do normally, and then exercise and stress management is extremely important.
So what are the reasons that rheumatoid diseases seem to affect women at a higher rate than men?
Again, no idea. That's something which we may learn later. I mean, again, in lupus, there are multiple theories, because in lupus, I mean, men are very few. Women are a whole lot. And there were these theories that, it's because of hormonal related, it's the hormones that affect it, but they've done study after study and found that that was really not the case. So the jury is still out on that. Again, in spondyloarthropathies, they thought about 7-to-1 ratio, 7 males to 1 female. So it wasn't a female predominant disease, it was a male predominant disease. But now we know that actually the ratio is 2-to-1. In women, it tends to be milder and they tend to get missed. They get misdiagnosed as fibromyalgia or something. And now there's some thoughts that it may even be 1-to-1 ratio male to female. So, I mean, there's a lot of thought process behind it, and hopefully we'll know one of these days, but to date, we don't.
Well, it's an exciting area for research then.
Definitely.
So would you say that one of the most essential things for preventing these really crippling joint deformities is getting on medication at an earlier stage?
Definitely. I think the earlier you're diagnosed, the earlier you get treated, the more your chance of going into remission. And I always tell my patients, these diseases, there's no cure for our diseases, for these autoimmune diseases. They're like diabetes, high blood pressure, there's no cure, there's treatment. But the good thing with our diseases is that with treatment, we can throw you into remission. And what that means is that you have no signs or symptoms of the disease. And when you present with remission, we start pedaling backwards. Like initially, we're adding medicines, more medicines, we start taking away the medicines. And I've taken several people off medicines and they have stayed free of disease for several years. Unfortunately, a lot of time they do make a comeback, but at least you get, who knows? I mean, and it's anybody's guess. You just have to follow them 2 years, 3 years, 5 years off medications. I've had even a patient who was off medication for 10 years and she just recently came back. So
that's amazing. A whole decade of improved life. Can you explain a little more about the other organs besides joints that can be affected by these rheumatoid diseases?
So what we see most commonly is, of course, the skin. Like I said, polymyositis, dermatomyositis, you can have skin involvement. Now, you have the heliotrope rashes and you have those. Again, with dermatomyositis, there's 10% association with underlying malignancies. So anytime you diagnose a patient with dermatomyositis, you make sure you do the age-appropriate workup for malignancy, CTs of the chest, the abdomen, make sure they're age-appropriate workup for malignancies, mammograms, colonoscopies, they are in order. Of course, with multiple of these diseases, the lungs can be involved. Interstitial lung disease can be seen. There's called, again, that's getting too technical, so I don't want to kind of confuse you more than I'm helping you. But I always check a baseline chest X-ray. If they do have any shortness of breath or anything, I always send them, for PFTs, HRCT. Sometimes even, with limited scleroderma, you can have pulmonary hypertension. So I always, depending on what the patient is presenting as. Kidney involvement, very common in people with lupus. And again, just looking at the BUN and creatinine is not enough. You always have to check the urine, because if there's proteinuria, that's not a good sign. So they all tend to be multi-specialty diseases, because, the rheumatologist is, so far as rheumatoid is concerned, we are the ones who are giving the main care. If there's lung involvement, I don't do PFTs in my office. So I do have to get the, pulmonologist involved. If I need a renal biopsy, I need to get the nephrologist involved. So it depends on, what system is affecting. Sarcoidosis can affect the lungs. It can affect the brain. I've had patient with the one I just told you came back 10 years later. Her only presentation, she had spondyloarthropathy, presented only with iritis and some back pain. Her main complaint was iritis, had gone to the ophthalmologist, and he referred her to me because the same medicines you'd use for any other of our autoimmune diseases are the ones that will affect the eye. So I had her on sulfasalazine and she did great. Her joint pains went away and she never had any, because iritis can make you lose your eyesight if left untreated. So pretty much head to toe, it can involve any organ. So you just have to be careful.
Are there any links between rheumatoid diseases and like cognitive decline and aging?
Oh, yes. And you mean increased mortality is what you're asking?
Or just
Aging
like deficits in cognitive ability?
Cognitive ability. Again, with chronic pain, that's always, like you see with fibromyalgia, the mental fog, that's there. With lupus, there are some studies showing there may be earlier cognitive decline. And depends, right? But if they're well treated, I really haven't seen it in any of my patients, but if you're asking theoretically, yes.
Okay. So our last two questions are a little more general. The first one is for any students who have been inspired by this and really want to pursue rheumatology, do you have any recommendations for things that they should read about or look into?
So yeah, if they are interested in rheumatology, I would highly, so one of the questions I get asked by my other students who rotate with me is, what's the earning potential? And that's not a whole lot higher than an internist. Maybe some, and of course, you have the infusions coming in and the medication and so on and so forth. But really, it's your passion. So either you like to do it, don't go into it if you're looking for big bucks, because, then you're looking into specialties like ortho and whatever, it's very satisfying. If you have any research experience, that's great. There's tons of clinical research on rheumatology coming out, like I said, and to the medications I'm using now, they were not there in 2000 when I graduated from my fellowship program. So lots of new information, and, read up as much on immunology as you can, because that's the basis. Everything is moving towards the cellular level. So I think that's it. And it has to be just your passion.
So our very last question, how is the work-life balance in your field?
I think it's pretty good. You can, we are not like surgeons, so things don't, they kind of move a little bit slow. Thankfully, of course, you can get, very, very sick patients with lupus in the ICU and so on and so forth as well. But by and large, you have time to think, you have time to scratch your head, and you can fix your, like when, when I started as a partner, I was the only female partner. So again, women have a little bit more onus on them to prove themselves, whereas men don't, unfortunately. But so you're looking after a family as well as, so I could, adjust my hours. So I would just work straight from 8 to 2. And that way, so I brought a lot of work home, with dictation and stuff in the evening. But so it just depends, work-life balance in any situation is what you want out of it. If you want to put in a lot of hours, a lot of money, the potential is there. If you want to work less hours and spend more time with the family, in that case, I think the salaried positions are more, they will be more lucrative, because at least because running your practice on your own, it's tremendous amounts of overheads. So whether you want to or not, you still have to work a lot. So in that case, salaried positions may be better. It doesn't, of course, have the satisfaction of running your own practice and being your own boss, but, that's an option that's there. So just depends what you want out of life.
All right. Thank you so much for your time today. You've given us a lot of insight into this really interesting field.
And thank you.
Thank you so much, Dr. Kheshgi. My name is Manahil. I just graduated from the University of Maryland. We really appreciate you taking the time to answer all of our questions and taking your time out of the day to mentor us, especially on the special day, Eid, which is a Muslim holiday. So we really appreciate it and taking the time to mentor us and teach us. And I'd love everyone to please give a warm thank you to Dr. Kheshgi in our chat box for this incredibly informative session.
Thank you very much. I hope everybody gained a lot out of this. Good luck.
Thank you.
And Eid Mubarak.
Eid Mubarak to you too.
Thank you.
All right, now we are going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live. You will need a 70% or higher to pass and receive certification. The link is going to be in the chat box now.
Now on to our next session dates. These dates will be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, July 16th at 10 a.m. Eastern Standard Time, so be sure to follow us at TeleShadowing. So thank you so much everyone for attending today's session. We hope to see you in upcoming sessions soon, and this concludes this week's shadowing. Thank you.